A very warm welcome to this first webinar in partnership between the Royal Society of Tropical Medicine and Hygiene and the London Centre for Neglected Tropical Disease Research. My name is Gail Davey. I'm currently President of the Royal Society of Tropical Medicine and Hygiene and absolutely delighted that this webinar partnership is going forward. So to this afternoon's webinar, after decades of conceptualizing, researching and bringing disease management, disability and inclusion to the fore, the launch of the WHO Roadmap 2021 to 2030 has brought a paradigm shift in the way NTD programs are being approached and delivered. In addition to the roadmap, publications developed in collaboration between WHO and NNN, the NTD NGO network, including the guideline, Mental Health of People with NTDs Towards a People-Centered Approach, have supported researchers and implementers as they put these principles into practice. So while there is increasing focus on disease management, disability and inclusion, there's still significant work to be done to ensure that NTD programs respond to the significant burden of comorbidities associated with them. It's vital that stigma, discrimination and mental health are considered in all NTD programs from now on. So this webinar will showcase research related to disabilities and neglected tropical diseases. We hope this will give the research the profile it deserves and improve dialogue. In turn, we anticipate this will help us identify operational research questions and ensure that neglected tropical disease programs are informed by best evidence. So I hope you enjoy this afternoon's webinar very much indeed, and I'm going to hand over now to Julian Eaton to chair the remainder.
Gail, thank you, and welcome everyone to this webinar. As Gail said, the new WHO roadmap on NTDs has really opened up a new paradigm. And that opens up a lot of research opportunities and lots of essential questions. How are we going to put in place some of the really important paradigm shifts that have been suggested? Moving more towards a cross-cutting perspective, with integrated care being more important, thinking much more about real-world impact and accountability, and thinking much more concretely and in much more ambitious ways about national ownership. So my name is Julian Eaton. I work at CBM Global, Disability and Inclusion as the Mental Health Director, and also at London School of Hygiene and Tropical Medicine, particularly at the Centre for Global Mental Health. We've got a great group of people to speak today, and then afterwards we'll be answering any questions that come. So we've got a lot of people, 250 people registered to come along today, and we'd really welcome your questions so that we can have a good and rich discussion after our presentations. Please do write your questions in the Q&A section section at the bottom of the screen there, and that will enable us to see what's coming up. And I think there's a means of voting there as well if you like other people's questions. So the people we have today, first of all, someone who will be very well known to all of you, Professor David Molyneux, who is the Professor Emeritus at Liverpool School of Tropical Medicine and also now the Editor-in-Chief of International Health. And Dr. Freddie Bailey, who's an Epidemiology and Information Analyst at Public Health England. We've got Dr. Paul Tsaku from Nigeria, who's the Research Advisor for the Leprosy Mission in Nigeria. And finally, Dr. Laura Dean, who's Research Director of the REDRESS programme, which we'll be hearing more about later. So without further ado, we're going to start with a couple of talks, first of all from David and then from Freddie, thinking about the comorbidity between mental health particularly and NTDs and what that means in terms of burden of disease. A little bit more by way of introduction before we go into those presentations. Professor David Molyneux is a professor at the University of Liverpool and School of Tropical Medicine. His major research interest was initially trypanosomiasis and leishmaniasis, but latterly he's become involved in parasitic and vector-borne disease control programs, advising WHO on trypanosomiasis, onchocerciasis, lymphatic filariasis, guinea worm, malaria control. The list is pretty well almost endless within the range of NTDs that he's worked on. But his recent focus has been on calculating the burden of mental ill health and the millions of people affected by NTDs and bringing this underrepresented topic to the fore. Then immediately following David, we're going to hear from Freddie Bailey, who's an academic doctor with a keen interest in public health. He spent a year working as a research assistant looking at the psychological impact of cutaneous leishmaniasis at the Liverpool School. And during this time, he found that the psychological burden of disease and other chronic NTDs is largely underestimated. We're going to hear about the work he's done since then to explore that question further. So without further ado, I'll hand over to David for his presentation. Thanks.
Thank you, Julia. I hope you can hear me. Is that working okay?
Yep, all working.
Fine. I'm going to share my screen with the starting slide. Just like confirmation that everybody can see that. Is that okay?
Yes, all working, David. Yeah.
Okay, well, first of all, thank you very much for this kind invitation, and it's a privilege to talk to such a large group, an enthusiastic group, about a topic which has been on my mind for about 10 years now. And I just want to go through the journey that we've taken. And it all really happened in an almost serendipitous way by a meeting at lunchtime when I met a student. I've got to move on. Hang on a second. Work out how I move the slides. That's it. met a student in the coffee bar in Liverpool, Lizzie Litt, who was looking to do a master's dissertation. And I'd had some personal experience of depressive illness, and it was interesting to look at the possibilities, because I suddenly realized that what we were working on in lymphatic filariasis at the time, there was a significant burden of mental illness that had been already attributed to that condition. And I just wanted to show you a couple of slides which I think really brings home to us the situation. And one is a slide from a female patient in India, where she said that the family had brought 2 suitors, but neither had decided to marry me. And the bottom right picture is somebody from Mafia Island on Tanzania, who said that when the filarial fevers come, my family have to look after me. And this struck a bell, because really it emphasizes the point that there are so many NTDs where, first of all, there's rejection and stigma associated with the condition, but also what we also looked at was the role of caregivers. And I think this is, again, an under-researched and underestimated feature, particularly when we're looking at what the actual burden of these diseases is. Now, this slide just simply shows the sorts of issues which might engender mental health and disability and stigma in the context of NTDs. And you'll be familiar with them in terms of the impact on educational disruption, the fact that children become carers, people are driven into a medical poverty trap from which they can never emerge, and that of course has impacts on the mental health status of individuals and families. The inability to work and therefore harvest, and the loss of cash crops, potential reduction in nutritional status as a result, and so on. And I think that this, in a sense, summarizes the bigger issues that we face. However, when I started to work on this topic, and I have to emphasize, as I'm certainly not a psychiatrist nor have any training in mental health, working with Taran Dua in WHO initially, looking at this WHO publication, Mental Health and Development, it became clear that when you looked at the executive summary of that document, the key features of mental health overlap so much with the NTD condition: stigma, physical and sexual abuse, restriction on rights, inability to participate fully in societal activities, difficulties in access to healthcare, barriers to education, and disability and perhaps premature death. So this struck me as being particularly relevant, but at the time, not really being fully cognizant with the issues around the global burden of disease, and then beginning to explore what the major burden of disease in the world is, it became clear, and it's been published, this dates back to 2004, the first global burden of disease study, that mental health and substance abuse are amongst the, if not the highest, causes of global morbidity. Now, I don't think there's any disputing that, but looking at the literature, we're talking about a huge burden of mental disorders associated with most populations. But in this study, which I've highlighted here, the global burden of mental illness and substance abuse, according to these reports, was in the high and upper middle income countries. Looking at other studies by Ferrari in PLOS Medicine in 2013, the statement depressive disorders were the leading cause of burden in previous global burden of disease studies, and they continue to be so. But the highest estimates of DALYs were in the higher income countries opposed to the lower middle income countries. And I've emphasized in red in the bullet there that none of these authors considered NTDs. And hence I've always believed that these studies in the global burden of disease are gross underestimates given the volume of mental illness which we know NTD sufferers have. Now, I've just listed here, and we'll hear about these conditions later on, and we're all aware of them as people who work with NTDs. And I've just listed some of those which have well-defined mental health and neuropsychiatric sequelae. We'll talk about one or two of them later, but what strikes me is that some of these conditions, filariasis, leishmaniasis, oncotrachoma, leprosy, snakebite in particular, have huge incidences, particularly the leishmaniasis and snakebite, as we can demonstrate. And Freddie will talk about the snakebite, and we will also concentrate on issues of disability weights, which I will not address specifically, but just to emphasize that the disability weight, which is so important in calculating the years of life lost in disability, are highly significant and worth comparing with other NTDs, which Freddie will address. We initially started this because we were working on filariasis, and we published a paper in 2015 with Tan Ton and Charles Mackenzie, which basically, with conservative estimates, showed that the attributable DALYs for mental health and depressive illness in filariasis patients was at least twice that of the attribution accorded by the Global Burden of Disease study in 2010. And that included attribution of DALYs to those who had to care for filariasis patients. The most recent studies by Bindo, including you, Julian, were that in Nigeria, the percentage of filariasis patients were with depressive illness were 42% with mild, 31% with moderate, and 26% with severe depression. But the median duration of that illness was 17 years. Now that's really significant when you're calculating the years of life lost, the YLDs, in terms of disability. Now, another factor in this was that I was working with Onco at the time, and the issue of the depressive illness in caregivers was significant. This is a study undertaken in India, but the takeaway message here is that nearly 50% of those who looked after people with gross visual impairment had depressive illness. It's important to compare that with depression in normal populations, which in the case of this study was about 15% in urban Chennai. But the point is that caregivers also suffer from major depressive disorder. Now, I think it's important to reflect on the work that was done by Tsaku de Vlas in terms of the amount of disability averted from the interventions in NTDs. But I want to use this quote because I think it's really important. And de Vlas and colleagues say, in particular, the choice not to include subtle morbidities in their calculations, that is, such as impaired cognitive development due to STH and schistosomiasis, or poor mental health from stigma and discrimination due to disfigurements caused by LF and leprosy, is considered an important omission. So the burden of mental health associated with NTDs does not appear to be included by the mental health community in calculations of depressive disorders and anxiety. And just to focus now on work we're currently doing, and this is work which has actually been funded by a small grant from the Royal Society of Tropical Medicine and Hygiene, but which was very interesting. I worked on sleeping sickness many years ago, and of course over the last 10 years or so the incidence of human sleeping sickness has declined considerably. But the question that ought to be asked is, of treated patients with sleeping sickness, and we all know the neuropsychiatric symptoms, many different neuropsychiatric symptoms in sleeping sickness, what proportion of cured patients have maintain those symptoms post-treatment and have permanent neurological sequelae? Are treated patients, as they are in cutaneous leishmaniasis, excluded from any DALY calculations? What is the caregiver mental health burden? and the impact on households. But undertaking recent studies in Congo with a really remarkable cohort of patients, working with this recipient of RSTM and MH grant, Julian Eaton, that pregnant women who gave birth having had a HAT diagnosis, their children show now, still 21 years after birth and having been treated immediately after birth, permanent irreversible neurological sequelae despite the successful treatment for infection. Now, this is a series of only 6 patients. Of those 6 patients, 5 have these really profound symptoms. Now, we don't know the extent of congenital sleeping sickness. We think it's much more than actually recorded. But the point I'm making is that treated children have these sequelae for the rest of their lives. Just to emphasize the caregiver scenario, this is a familiar picture, an onco patient being led by a child. The picture of this lady in Mafia Island, my family has to take care of me when the fevers come. And the studies we're doing on Buruli ulcer in Kumasi with Richard Phillips and Yao Amako, who are looking at Buruli ulcer and the impact on the mental health of caregivers of Buruli patients, a paper which is now in press with PLOS NTDs. And this emphasizes the importance of integrating the psychosocial interventions in Buruli management and the impact of the condition of patients on the caregivers in terms of the mental health of those individuals. Now, I just want to finish by emphasizing the issue around snakebite. Because as Freddie will explain in the next talk, it's the incidence that matters. In snakebite, we have an annual mortality, and these are figures from the WHO roadmap, an estimated annual mortality of snakebite of 80 to 140,000 individuals. 100,000 is a sort of figure which is often used, with 2.7 million snake bites annually. But the estimate of disablement is that 400,000 individuals are disabled annually from snake bite. And the study that we quote here is that some of the studies that were done in Sri Lanka show that 25%, 38% and 33% had respectively mild, moderate and severe depression. These are ongoing studies with Rob Harrison, Ruth Shelton and Saeed Ahmed to try and define what the global burden of major depressive disorder in snakebite actually is. But given that these patients suffer if they survive a snakebite in a variety of ways and will be dependent very much on caregivers, perhaps having had amputations, they will be unable to farm and undertake normal activities. This is a huge number of potentially disabled people if we've got that level of incidence of disability, given that, assuming they don't die earlier than anybody else in the population, this will be a huge burden of years lost in disability, YLDs. And perhaps the most profound impact that I had was with Dominic Keelem, one of our former students who tragically passed away some years ago when he was working with the task force in Atlanta. This is from a village in Burkina Faso where some disability management had been taking place, the traditional way of washing the feet. And this lady stated, after this, I can now go to market. I can go to market and collect water. She was not able to do this before she embarked on this course of limb care. And I think that really emphasizes for me the change that can happen when people are cared for, they're given the correct treatment and simple measures can be adopted. And that ability to socialize by somebody with filariasis, and I think the same can be applied to other conditions such as podoconiosis and so on, is critically important for those individuals' mental health. So thanks to a whole range of people for their contributions over the last decade to this work. I hope it's able to continue. and I'm now happy to hand over to Freddie Bailey, who will talk about the specific work he's done on cutaneous leishmaniasis. Thank you, Julian.
Hello, everyone, and just want to start by saying thank you to Catherine and Julian for inviting me to speak at this really important event. It's a really important topic, and I'm very happy to be with such distinguished co-speakers, so thank you. So I'll just speak to you in the next 10 minutes or so about my work on cutaneous leishmaniasis, which I did with David and Alvaro Acosta Serrano at the Liverpool School of Tropical Medicine. There we go. Perfect. So you can see from this table, which is an overview of the kind of state of play of holistic and psychological studies for NTDs, that cutaneous leash is quite a well-studied NTD. And combined with the fact that it has an incidence rate of 1.2 million active infections per year, this was a kind of a good example NTD to build on further work that David had started previously with LF. So cutaneous leishmaniasis, when I started studying the psychological impact of this NTD, it became quite apparent early on that there was quite a big difference between how the scientific community was viewing the disease, mainly in terms of disease control, and classifying it in terms of its geographic spread, its mode of transmission, or the extent of its lesions. Whereas reading the literature, it was very obvious that the patient experience was a lot more holistic and wasn't necessarily restricted to just the active cutaneous leishmaniasis lesion. So as a result of that, we actually coined a couple of terms. We coined active CL, which refers to this plaque or ulcerative lesion here, and also inactive CL, to cover the residual scarring, which occurs in almost all cases. So our next step was we looked at the prevalence and the disease burden estimates for CL, and this was the prevalence that we saw at the time of 4.3 million cases of CL. Now I've just told you that the incidence rate was 1.2 million, so there's no real way that a non-fatal skin NTD could have such a low prevalence if residual scarring were included within the prevalence and therefore the disease burden estimates. So, and because we knew that the scar itself is very stigmatizing, we felt that we needed to generate a baseline estimate of inactive CL. So we did that based on a very conservative life expectancy of just 20 years and using an underreporting factor as well. So we've kind of increased the prevalence from 4 million to about 38 million. And you can imagine that is automatically going to have an impact on the disease burden estimates. So this is the kind of methodology we followed to determine the psychological impact of CL in terms of DALYs. DALYs are a combination of years of life lost due to a condition, combined with years of life lived with disability from a condition. So in the case of CL, we only looked at the disability angle of the DALYs. So the YLD is the years lived with disability, and that is a product of the prevalence of a disease, so the 38 million cases that had, and a disability weight, which I'm just going to touch on now. So these are the disability weights, and a disability weight ranges from 0 to 1, and 0 represents full health and 1 represents death. It's based on a survey of expert opinion, and it's simplified such that it's simplified into categories. So for example, there's a category called disfigurement level 1, and that accounts for any cause of such disfigurement, and that can range from goiter to hernia to leprosy. So that it's not really distinguished. I just want to point out as well what appeared and still appears to be, because these are 2009 figures, a bias towards physical conditions. So you can see here for the NTDs, leprosy, disfigurement level 2, some kind of moderate impact leprosy, has a disability weight of 0.067, which is equivalent to the disability weight for CL as well, and is similar to acute adenolymphangitis in LF. Whereas this is actually half of the so-called impact, the disabling impact, as other physical health conditions such as very mild drug dependence is actually a quarter of the impact of a medication overuse headache. So, and the key point here is that disability weights are the key way of capturing all of the additional impact of an NTD, including the psychological impact. So it was very clear that the disability weights aren't sufficient to capture this. So what we did was we did a systematic review, and we found 29 studies, which is quite good for an NTD. And they covered 11 of the 50 highest burden CL countries. Interestingly, we didn't find a difference statistically between the psychological impact between active and scarring cutaneous leishmaniasis. But importantly, we did find a significant increase in all categories. So diagnosis of depression, symptoms of depression, quality of life, and stigma compared to controls. And that was with both active and inactive CL. So that kind of validated our use of creating this alternative classification for this disease. This is a model which we used to we didn't use it in our ultimate estimates, but in order to kind of capture all of the different aspects of psychological impacts of CL, we used a stage model of depression, which has been championed by Vikram Patel and others. So we found, roughly 50% distress among individuals with CL, and a clinical, symptoms in keeping with a diagnosis of clinical depression in 20%. And that's a very rough estimate because we actually found 50% rates of depression in our studies. So when we added in inactive CL prevalence, as well as disability weights for depression within CL, you can see that the numbers, well, I'll show you the table in a second, but the numbers of YLDs, the disability aspect of the DALI, increased, so increased by about sixfold. So whereas CL, previously only using the active infection, had a total of 270,000 YLDs, which was rank 8th total NTD by YLD burden in 2016. When we added in a more appropriate, what we felt more appropriate inclusion of psychological impact, it increased by sixfold, and it actually became the second highest NTD by disability burden. So a couple of caveats to that. I mean, I've said that we were very conservative in estimating the prevalence of CL in the scarring aspect of CL. We also only included depression. We didn't include any subclinical forms of psychological impact. We didn't include anxiety. Yeah, and yet it's still kind of coming up very high in the overall rankings. So I just wanted to leave with this. I mean, David touched upon LF, snake bites, Burley ulcer, we've been working on recently as well. And other colleagues on the call have been working on different NTDs as well. But I just wanted to pose a question of what do we think the true burden of NTDs would look like if we did adequately account for the psychological impact. So thank you very much.
Thank you very much, Freddie and David. I think that's given us a really good foundation to what we're aiming to achieve in the session today. A really good way of looking at some of the theoretical underpinnings that have maybe caused a neglect of a person-centered approach historically, reinforced by the kind of language that we've historically used. And all that kind of work and strong advocacy really from people working in the field has led to this new approach, a new paradigm that the roadmap has given us. What that enables us to do, of course, is to be arguing for greater investment in real world change on a programmatic level in countries particularly. The next couple of talks we've got are going to start to explore maybe some of the more operational research that's going on to understand how we can really apply that learning in practice. So we've got a couple of people who are going to be presenting their work for us. First of all, Dr. Paul Tsaku, who's a researcher with the Leprosy Mission in Nigeria. His current research interest is on transforming treatment and promoting well-being of people affected by NTDs. He holds a PhD in medical microbiology from Nasarawa State University in Nigeria. So I'll hand over to Paul now. Thanks.
Okay, thank you very much, Julian. I believe everyone can see my screen now. Can you confirm that, Julian?
Yes, very well. Go ahead.
All right, thank you. So I will be speaking on transitioning from theory to practice and implementing evidence-based programs that are person-centered in NTD elimination, control, or eradication. And the focus is on the neglected mind-skin link project, which is currently ongoing in Benue State, Nigeria. The project is being carried out in collaboration between the University of Jos, Nigeria, the Leprosy Mission Nigeria, which I represent, and the CBM, with funding from the UK government through co-NTD. So the project title is The Neglected Mind-Skin Link, Promoting Mental Health and Well-Being of People Affected by Skin NTDs, Formative Piloting of WHO Guide on Mental Health and NTDs Integration. So thanks to Professor David Molyneux, he has given us some basic introduction on the NTDs and mental health link. Basically, some documented reports place the prevalence of NTDs and psychological comorbidities to be as high as 76%, with Nigeria as a very high burden region. And one of the problems of NTDs is that stigma is very much associated with reduced help seeking and low adherence to treatment. And it is very well known that insufficient funding and resources is not being allocated to tackle the burden in low and middle income countries. And Benue State in Nigeria, where this study is presently ongoing, is a place with a population of about 5 million people, with just about 5 trained psychiatrists in the state. So the gap is quite huge in the state, and all the 5 psychiatrists are located within one local government area, which is the state capital, whereas there are 23 local government areas in the state. So integrating mental health and psychosocial support and care in NTD services for people with NTDs and their families is likely going to improve access to care and may reduce stigma, and if well designed, may facilitate broader well-being and achievement of social priorities. So the research questions. The primary question is on the feasibility and acceptability of implementation of a model of integrated mental health care based on WHO guide on mental health and NTDs integration. And other questions are on the priorities of service users with NTDs in relation to their quality of life and well-being, the social and economic effect of additional mental health problems and psychosocial disabilities, and the rates of depression and anxiety among service users with visible signs of leprosy and lymphatic filariasis based on some demographics, and then the attitude of primary care staff to treating people with NTDs. So I mentioned earlier, the study site is in Benue State, central Nigeria, and presently we are focused on 2 local government areas of the state, that is Boko and Konshisha. And this is a site where the 2 partners in this study, the TLM Nigeria and the CBM, have been working with people with NTDs. So methodology. This study, the approach to this study is basically mixed methodology of qualitative and quantitative methods. And first, there is a measure of depression, anxiety, and well-being using PHQ-9, GAD-7, and WHO-7 tools. And based on the outcome of this measure of depression, anxiety, and well-being, gender disaggregated focus group discussion is being carried out. So these pictures are some of the engagement with the study participants in the site. We have people with lymphatic filariasis and people with leprosy. And here is one of the focus group discussion with the females and a focus group discussion with the males. So basically, from this, what we discovered is that we were able to assess 73 people with leprosy and 68 people with lymphatic filariasis. In total, we have 141 persons, which we recruited into this study. And we also have a control of people without NTDs who are of the same age and gender with each of the person that we recruited in the study. So our findings is on the prevalence of well-being, on well-being, prevalence of anxiety and depression is that we found out that up to 46% of people with leprosy have poor well-being, and as compared to people without NTDs, 27%, and in the case of lymphatic filariasis, 42.6%. In anxiety disorder, people with NTDs, we found up to 48% with anxiety disorder, and in the control group, we have 29%. So in the case of depression, people with NTDs, we have about 60%, 60.3%, and then 31% in people without. Now, these are just some of the basic analysis of our study findings. We also have a community engagement, and these are some of the pictures where we have a meeting with the state primary health care director, and then here is an engagement with the NTD's director of the state, a mental health director of the state, and here is with some of the community leaders. So we have a theory of change workshop, which is a theory-driven approach to design complex interventions using participatory methods. And basically, in theory of change, there are what we call the 5 key components. And normally, the theory of change is being carried out working from top to bottom or backward movement, where we work from the ultimate outcome through interventions, indicators, rationales, assumptions. And then ultimately there is what we have ceiling of accountability. Now, in our theory of change workshop, which took place in February, it was a process, both a physical and a virtual process. A virtual process in the sense that our colleagues who are working from outside Nigeria, as we are very well aware of the COVID-19 situation with the travel restrictions, where they were able to also participate in the theory of change workshop as well through online platforms, Zoom, which they kind of participated in the theory of change workshop. And here are some of the images from the theory of change workshops, where we invited representatives of persons with skin NTDs, persons with leprosy, persons with lymphatic filariasis, some community leaders, primary care workers within the communities where the study is taking place, and then stakeholders from NTDs and mental health within the state were all invited. So they worked throughout the process, where a theory of change map was drafted. As we can see, the theory of change map, which the ultimate outcome or the impact that is expected is that people with NTDs have improved well-being, community inclusion, and are able to achieve their aspiration. So here we have a map which outline all the strategies on how to achieve that. And then you could see that the community have a role to play, the health system and the governance structure have different roles to play. And the activities that are key outlined in the theory of change map is the user group facilitation, community engagement, training, system strengthening, policy framework, and advocacy. So here are also some of the indicators and their assumptions from the TOC map. Now we also have a training of healthcare workers because the huge gap in mental health services as a process, as a way of bridging that gap. There is also an activity which includes training of the healthcare workers on mental health, which they were taken through the WHO Mental Health Gap Action Program modules. And it took place in the Benue State as well, where we invited community healthcare workers and nurses from the two local governments where the study is currently taking place. So then there is going to be some of the activities is to make some referrals where the healthcare workers that have been trained and identified, we will be referring the identified cases with anxiety, depression, and poor well-being for psychosocial support. And then there is community engagement and awareness creation on NTDs and mental health, which is supposed to create awareness in order to reduce stigma. And then there's training of NTD workers, and definitely we have some support supervision outline for the trained workers. So these are some of the process of our engagements while we plan, because the members of this study team are from different locations. Now, some of the challenges is that the initial start of the process of the project was affected by COVID-19. And then I also mentioned about the theory of change, but which we have to make use of an alternative, which is the virtual process. And then time, of course, the people with NTDs are considered neglected, and it's a bit difficult reaching them because the access to technology and access to basic amenities is a bit difficult process reaching them. So it takes a lot of time to be able to reach people with NTDs, and specifically, and then insecurity was a problem. Especially in the location of study, there are issues of insecurity which affected some of the process at times, and then we find it a bit difficult getting our target respondents. And there's no doubt we are working from very remote communities, and accessible routes, it's a challenge. So thank you very much for listening.
Thank you very much, Paul. It's really fascinating to hear about the practical means by which we can start applying these international frameworks in practical ways in countries like Nigeria. And I know that we'll be discussing more of that in the questions and answers later. Thank you all for the questions that are coming in. There's a really a great diversity of questions there. Maybe I can invite the panelists to have a look at those while they've got a few spare minutes to maybe think about some of their responses to those. But we're going to hear now from Laura Dean, who's also really got great experience in engaging with communities and trying to make real that aspiration to include people affected by these conditions in the types of services that might benefit them most. So Laura is a social scientist with over 10 years of experience of research, capacity strengthening and partnership for community-led development and health system strengthening in Africa and Asia. She is a research director of the REDRESS program, which stands for Reducing the Burden of Severe Stigmatizing Skin Diseases, and works through equitable person-centered approaches to health system strengthening. She's working in close collaboration with the Ministry of Health in Liberia. So let me hand over to you now, Laura. Thanks.
Thanks, Julian, and hopefully my screen is sharing. So thanks everyone for having me to present today and coming to listen. It's really great to be here. And I'm going to focus my talk around how we can support the development of health systems to shape person-centered responses to NTDs, with the ultimate view of promoting holistic disease management and disability inclusion across the whole continuum of care for NTDs. The work and learnings that I'll draw from today are taken from across a series of different implementation research projects, all of which work with people affected by NTDs, health workers, district, regional and national programme managers to support a shift in thinking towards more person-centred care. And the learnings draw from across multiple contexts, including Nigeria, Liberia and more recently DRC. So I wanted to start by helping us to think about what this means in practice. So we hear a lot about person-centered care in NTD programs, particularly with the release of the new NTD roadmap. But person-centered care has of course been integral to part of health system strengthening efforts for many years. and is largely defined as an approach to care that consciously adopts the perspectives of individuals, families, and communities, and sees them as participants and beneficiaries of trusted health systems. And most importantly, we should be responding to people's needs and preferences in humane and holistic ways. Many different frameworks also exist that can support us to think about person-centered health systems. And the one that presented here shows us the importance of putting people and households at the centre, whilst also thinking about the wider context of service delivery, health sector governance, the national and global policy environment, as well as the role of other sectors. But thinking compassionately and humanely is also key to developing these person-centered services. So who are the people we are thinking about when we think about person-centered and disability inclusive responses to NTDs? Well, we might be thinking about people like John, and John is a teacher living in Liberia. And during Liberia's civil war, John experienced severe itching on his skin. And this itching was caused by onchocerciasis or river blindness and could have been easily treated by swallowing ivermectin. But for John, however, this tablet was not available. And despite trying to access healthcare on many occasions, which are shown by the different markings in chalk on the wall that's presented here, he was unable to access the care he needed, eventually going blind. And this has led to John facing many challenges of social isolation and exclusion, including losing his job as a teacher, being abandoned by his wife and family, and experiencing suicidal thoughts. So if we think about John's story and a necessary continuum of care for NTDs, which is essential to achieving person-centered health systems, what we can see is that people at risk who may or may not experience signs and symptoms need equitable access to preventive chemotherapy interventions. And this includes in settings that are hard to reach due to ongoing conflict or instability, but also amongst socially hard to access populations. And if we think about people with disability and promoting inclusive access, the way NTD preventive chemotherapy programs are currently structured, reaching these groups is infrequently a priority. In many cases, has been articulated by the previous speakers and shown in John's story, many people who are impacted by NTDs require more longitudinal support, often described as disease management, disability and inclusion. And at this end of the continuum, we can think about 3 or 4 pillars of care that may be required to ensure a holistic response to NTDs. This includes early case detection and diagnosis, rehabilitation, stigma reduction and political participation, and strong support networks for affected persons, caregivers, and their communities. But it's only when we think about inclusivity across this whole spectrum that we'll really achieve person-centered, high quality of care for affected persons that can contribute to disease management and, where possible, elimination. I'm going to focus the rest of the majority of my presentation at the DMDI end of the spectrum, given the purpose of today's webinar. But before I do, I just wanted to share one example of how simple it can be to prioritize the inclusion of people with disability in preventive chemotherapy interventions when the right stakeholders are brought together. So within our Countdown project in Nigeria, we use participatory research methods with community drug distributors and program implementers to identify implementation challenges. One key challenge identified was a lack of knowledge and awareness regarding how to administer medicines to people with disabilities, largely because many were unable to stand and therefore could not be measured with measuring sticks, or if they suggested measuring people lying down, this was associated with the measuring of corpses. People with mental health conditions and/or psychosocial disabilities were often also described as chronically sick and so therefore excluded from treatment campaigns. So to address this challenge, we brought NTD program stakeholders and disabled persons organisations together to design clear treatment guidelines regarding the inclusion of people with disability, as well as including disabled persons organisations in the delivery of subsequent training activities. And this has led to greater disability awareness within the programme, as well as encouraging many community drug distributors to seek out people with disability in communities who are often hidden due to stigma. So if we think back to our person-centered framework, we can see that by thinking about the specific needs of people with disabilities, we can adapt service delivery approaches through collaboration with other sectors that enable more person-centered care at the acute end of our NTD continuum. So moving to the other end of the spectrum, we've heard a lot about the burden of NTDs and mental health conditions, and Paul has begun to introduce some ways we can think about tackling that burden. But we often think about disease interaction from a medical perspective, and most of the work that we've been doing has focused on working with people with lived experiences of NTDs to support a more detailed understanding of the mechanisms that shape these experiences. And this has been essential in developing cross-sectoral health interventions that can support the development of person-centered health systems that mainstream disease management, disability and inclusion for NTDs. And we're currently working to pilot a lot of these interventions. And so this slide presents an overview of our findings through an adaptation of Mendenhall's model for syndemic approaches to health. And this illustrates the mechanisms that we often see shape the relationships between NTDs, mental distress, and disability. So what we know is that limited healthcare and health information worsen NTD-related impairments, and they can exacerbate mental distress. For some NTDs, for example, leishmaniasis, there are also neurological pathways that shape these interactions. What we also know is that in many places where NTDs exist, multiple general stresses such as precarious livelihoods, food insecurity, weak health systems, poor water and sanitation may contribute to periods of mental distress among the general population. But these stresses also present a risk environment for experiences of chronic morbidity and disability resulting from NTDs. When these daily life stresses interact with additional stresses as a result of living with an NTD, such as somatic experiences of pain or functional limitation, changing abilities to complete daily routines, and the social meaning of disease, so stigma and discrimination, we often observe an excessive risk environment for mental health conditions amongst people with NTDs. Of course, these experiences are not the same for everyone, and we have to also consider age, gender, and geography, as well as other identity-based characteristics in shaping NTD-related illness experiences. Currently, in many settings, NTD programs are still grappling with how to deliver disease management and disability inclusion services, and as such, there's often a weak response to the needs and priorities of affected persons and their families, particularly in establishing referral and coordination with mental health services, which in themselves may be relatively weak. So what does this interrogation mean for health systems' responses to NTDs? Well, primarily that the social world that people live in can't be disconnected from their lived experiences. And we have to think about the medical, social, and psychosocial responses that NTDs require together, and that people with lived experiences are central in helping us to develop such responses. So within REDRESS, we're working closely with the National Ministry of Health, primarily the NTD programme, to take some of these understandings and develop a person-centred approach to NTD care. And this work builds on Liberia's integrated case management plan that was established to enable integrated care across multiple NTDs following the Ebola outbreak, primarily brucellose, leprosy, hydrocele, lymphedema, and yaws. Within REDRESS, we use a participatory action research approach to address multiple health systems weaknesses that are currently limiting high-quality person-centred care for NTDs. This participatory action research approach means working with people with lived experiences like John, health workers and communities to further understand their challenges and co-develop intervention-based solutions. We work across 3 interconnected intervention areas in REDRESS: promoting early case detection and referral, enhancing human resource management, and integrating mental health and stigma reduction within the NTD programme and general health system. And health financing cross-cuts all of these areas. I'm going to focus an example today on our work looking at integrating mental health and stigma reduction. And participatory action research relies on working in equal partnership with communities and affected persons, and certain research methods lend more to this approach. One such method is photo voice, which simply means sharing through photographs. But firstly, I wanted to explain to you the importance of peer researchers within REDRESS And peer researchers are people like John who are living with skin disease as well as health workers that live in the communities. And we train these individuals to support research and act as researchers so that they can shape action and change within their own communities. People with NTDs often rely on traditional and faith healers to support them, both medically and emotionally. And these groups also play a huge part in stigma management within communities. So to begin to define areas of collective action with faith healers in managing NTDs, our peer researchers worked with them to use cameras to document and share experiences from their practice. And for those of you less familiar with photo voice, this involves faith healers and traditional healers taking photos related to issues that were important to them for 2 weeks in their communities. Our peer researchers then discussed these photos with faith and traditional healers individually. And traditional and faith healers then picked 10 to 20 key photos that represented key issues to them to discuss together with their peers. And through an exhibition of these photographs and discussion, we worked together to develop solutions to the challenges and strengths that they had identified. These are just some of the photos from this kind of photo voice activity that I wanted to share with you today. And they highlight some of the important things that we have to consider when we're thinking about holistic treatment and disease management for NTDs. Firstly, that alternative forms of healing and treatment are particularly important, and so that medical intervention alone, without things like prayer or addressing more spiritual causes of disease, are likely to be ineffective from the patient's perspective. Also, traditional healers can play a key role in supporting wound management, where the health system may be particularly far away or inaccessible. And with the right training, they could be a really useful asset within communities to support these activities. And this slide just emphasizes what I said earlier about the importance of addressing the kind of spiritual or more African understandings of some sicknesses, and that Western medical intervention alone may be insufficient. I also wanted to highlight the important role that faith and traditional healers often play in providing counselling and psychosocial support in communities, because often they're very well trusted. And this slide emphasises an example where somebody needed specific intervention and support from a faith healer because they were particularly struggling with the fact that they were living with a skin disease. And finally, there's already often in many settings existing community-based mental health interventions that NTD programs can benefit from. So this is an example of trauma healing classes that have been taking place in Liberia since the end of the Ebola outbreak. And these activities bring community members together to share their experiences and work through experiences of trauma. So we're now working with these groups, the NTD program, mental health department, to design community-based stigma reduction activities and adapt existing mental health tools, such as a psychological first aid manual, to promote training, support and collaboration between the formal health system and traditional and faith healers to enable a more person-centered and holistic approach at community level to disease management and disability inclusion. This is just one part of working together with communities that's central to REDRESS, and we continue to also work with other health actors across our interventions to develop person-centered responses. And so I know I've covered a lot today in what probably feels like a bit of a whistle-stop tour of NTDs and continuums of care, but what I hope that I've illustrated is that co-production with community stakeholders, health workers, and people with lived experience is critical to unlocking solutions to everyday complexities that shape development of person-centered responses to NTDs. That person-centered responses require adaptations across the continuum of NTD care, and that collaboration within and between sectors is essential in adapting service delivery and promoting change. And finally, I've not focused very much on health sector governance or the global policy environment, but I'd just like to highlight a few key points that are key in shaping the shift from disease control to an integrated person-centered response to NTDs. Firstly, we must maximise the window of opportunity for policy change that the new NTD roadmap and associated master plan developments present, for example, through continuing to move away from disease silos. Secondly, we must lobby donors and programme implementers to shift their thinking and allow flexible funding that supports integrated models. And I appreciate that that's easier said than done at the moment in the current funding climate. Thirdly, we need to strengthen mechanisms of participatory health governance to include persons with lived experiences in all decision making around programme and policy design for NTDs. And finally, we have to continue to recognise the broader social impact and context of the interactions between NTDs, mental health and disability. So thanks a lot, and please do check us out at these different programme websites and get in touch if you have any more questions.
Thank you so much, Laura. That was quite a whistle stop, but has really enabled us, I think, to come to a great place for the question and answer session. We've had a really great number of questions, over 20, which I've tried to kind of put together into groups, but we'll try to cover them as much as possible. I think one of the things that you've illustrated really well, Laura, is the way that we're not talking about disability and inclusion, taking a person-centered approach as being isolated in any way, but it really fits in neatly with the kind of previous generation of work that's gone on around control and elimination. And one person in the questions, I think it was more of a comment in a way, was that, well, surely we could reduce this disability and suffering by reducing illness, by identifying people earlier, treating them more effectively, and then being able to take forward a change in people's lives. And I suppose by extension, that's also the case with the elimination, that actually, although you don't see the suffering, you're preventing a substantial amount of suffering. So a lot of the work that's really building on the kind of frameworks that Laura's presented there, much of this done by a really diverse group of people on the NTD NGO network side, as well as researchers, has been towards developing essential packages of care. But one thing that I want to ask Paul, first of all, to start us off is, this is all very well, all this good research that's happening that might even lead to really practical tools. But one of the important things about the roadmap is that we need to have national ownership. How can all of this research really be taken up by national programs, do you think? What can we do to encourage the kind of shift in emphasis that has been encouraged in these frameworks at a national level?
Thank you very much, Julian, for that question. I will respond by saying that we are already identifying stakeholders which we are engaging. What we intend to do is to be able to get stakeholders buy-in. So we have been identifying relevant government officials, which we've been having talks with them, and hopefully they can be able to give attention to what we are doing. Thank you.
Great. Thanks very much, Paul. That's really clear, and those relationships are completely essential, aren't they? So one of the other kind of major sets of questions that's been asked about is, how do we define mental ill health? And Freddie said very clearly that in their work they really focused on depression, for example, as one way maybe you could find the evidence around burden. But people in the questions have pointed out that, well, it's such a continuum, might be defined differently in different cultures. What about epilepsy? You know, these neurological and neuropsychiatric often intermingle. So I wonder if you could say something about that, Freddie, and maybe particularly about how useful that staged model was for you, and whether it could be framed in a slightly different way, maybe with different percentages, to apply to estimating disease burdens for other conditions. You're muted, Freddie.
Yeah, definitely. Thanks for the question. I think, you know, one of the key things that came out of the research was, if the only way to estimate any kind of psychological burden, however we're defining that, is through, you know, a very small decimal number, then we're probably not going to capture the full impact. And so I think that's kind of an important start. In terms of stage model, though, I think that is a nice alternative, because it doesn't just limit you to very Western ideas of mental illness as defined, within major depressive disorder, or, a depressive episode, depending on how you're classifying it. So I think, having elements of subclinical depression, which can be just more widely understood as distress, I think is important. I think the DALI model is not fit for the purpose of actually integrating different aspects of disease burden there. So I think I can't really see a way within the current system of kind of marrying the two, to be honest.
Mm-hmm. Thanks, Freddie. Maybe I can hand over to David to take that a bit further. Do you think it's helpful just to focus on depression and the concrete numbers we have, or do we need to use different methods to understand what the broader impact maybe of, right from emotional consequences of exclusion, for example, through to neurological consequences? How can we bring all that together?
Well, I have to say that I'm not a psychiatrist or a psychologist, Julian, so I'm really reluctant to go into settings I don't fully understand or professionally qualified to comment on. I would say that there is a spectrum, of course, and there's a condition, anhedonia, which is inability to feel pleasure or loss of ability to feel joy. So, I mean, there is this spectrum. We used depressive illness because when we were looking at the literature initially with filariasis, that's what other authors had used working in settings, for example, in India or in Sri Lanka or in Haiti, who were local researchers. And for that reason, and also because of the personal experiences that depressive illness can be insidious and long-lasting, as we know, it was an obvious place to start. Certainly it was obvious to me as a non-psychologist, because looking at the burden of disease, and this, as you know only too well, depressive disorder is the condition which has the highest burden of morbidity in the calculations of the global burden of disease. Now, yeah, there are many critics of the global burden of disease study, but if you've got some kind of marker which global health policy actually adheres to, probably far too much, we had to find a starting point. I would certainly be happy to defer to local psychologists and psychiatrists, and I think that really importantly to point out that the work that Gail Davies' team did in Ethiopia with podoconiosis was dependent on local psychology and psychiatric professionals who were well tuned to understanding the cultural setting in which that work was done. And I think that is absolutely critical. And Laura's pointed out that aspect of the situation and what we should be doing in future. So my feeling is, and we started this, Julian, frankly, because we wanted to advocate for, as an advocacy tool, to get not only recognition that mental health was an important part of the suffering and daily lives of people with these NTDs and their carers, but because we felt that, in part, that the NTDs were actually being underestimated by the GBD studies. And just go back to the calculations that Freddie did, because when we were discussing how we approach this to publish this paper, we had the globally defined disability weights. But years of life lived with disability, we had to pick a figure. And we put both for filariasis and for cutaneous leishmaniasis, we grossly, in my judgment, underestimated the years of life lived with a disability. If you look at cutaneous leishmaniasis, first of all, it can afflict young kids, particularly in refugee camps, for example, Afghanistan, Yemen, wherever you are. Those children are going to be afflicted with scars for the whole of their lives. We use 20 years, but if you look at the mean life expectancy in the Middle East region, it is 60. So that figure, which Freddie rightly calculated based on the 20 years, could be double. You know, if you're a young female who is afflicted at the age of 4, 5, 6, living with scars for 50 years, that is 50 years living with an irreversible disability. And so I think our calculations are inordinately conservative. And I would say that also for filariasis, because we chose in both those calculations only to use 10% of the people we were using for calculation purposes as having severe depressive disorder with a disability weight of 0.6. Looking at the studies that you did in Nigeria, it is much higher. It is 30%. So I think we're underestimating the figures. And somebody's pointed out in the chat box in the Q&A about leprosy prevalence. I mean, these figures are driven by what the prevalences are. But look at snakebite. I mean, 400,000 annual causes of disability. And again, 30% severe depression in the studies that have been done. And these studies have not been done by, and there's something in the Q&A about the global north perception of mental health. I can't comment on that. All I can say is that the studies we're talking about were not done by northern scientists. They were done by local psychiatrists, epidemiologists, and so on. So the context is, in my judgment, well, the context and the attribution of illness is based on local psychiatrists, as we see from the work that was done in Ethiopia, Sri Lanka on snakebite, etc.
Thanks, David. I would completely agree with you that depression is the obvious place to start. You know, that it is so dominant in numbers, and we know that it's a very good way of saying, look, this is the kind of scale that we're talking about. You also mentioned the importance of using local practitioners in mental health, for example, to make these diagnoses. But I just want to reflect on one of the questions that was asked, and maybe I'll ask Laura, and Paul might have something to say about this as well. That most people actually don't think, I'm feeling low in my mood, this is a medical issue, I'm going to see a health professional for this problem. They're much more likely to go to a spiritual healer or a traditional healer. And one of the very pertinent questions here is, what about local means of addressing these kind of emotional problems? And Laura, I wondered, in the work that you'd been doing in Liberia, Nigeria, and other places, whether the role of traditional healers or non-medical means of addressing distress came up often.
Yeah, a lot, and that's why we undertook the kind of work directly with traditional and faith healers, because I think often when you're feeling distressed or upset, or maybe even experiencing kind of a more complex mental health condition like depression, the people you're likely to talk to are people you trust. And I think often communities and people who are affected by NTDs are, the trust with the formal or the kind of biomedical health system is obviously not as strong as perhaps it is with some of these more kind of traditional forms of healing, or indeed healing that's linked to religion or faith, that where people can find a lot of kind of solace and support. And so I think often where we maybe go wrong in terms of how we think about mental health and interventions is we think about interventions that we think are needed in the West, so perhaps formal counselling or different types of kind of behavioural interventions. But actually, I think community-based talk therapies and who delivers those talk therapies can be hugely impactful.
Yeah.
And then I think the other thing that I would say that I think we need to be quite careful about when we talk about disability related to NTDs and how we think about it is that things like scarring or lymphedema, they're physical impairments, but what is making them disabling and really impacting on people's quality of life is the kind of attitudes of society and the way people respond. And so I think measuring the burden using disability adjusted life years and things like that is really important, but people with NTD related impairment can lead a good quality of life if we put the right things in place to support them. And I think that's what we need to kind of shift towards as well as we start to think about how we shape person-centered care to address these issues.
Thanks. Yeah, I completely agree with that, and a couple of people in the questions have talked about stigma. So it's that intersection of how a person looks in this case often and how people react to them that really matters. And Paul, maybe I can just turn to you to ask about your experience of working in this area for quite a long time, about the role of stigma and maybe what we can do about that to not only be looking at supporting individuals but changing the environment in which they live as well.
Thank you very much. What I think is from our study or from our works, actually, one of the things that we are trying to do is to create awareness. And by creating awareness, we have to involve other healthcare workers, community nurses and NTD workers as well. So on the issue of involving traditional healers, the traditional healers have a very important role to play, but primarily we have the gap is quite huge, and in order to cover it, we have to start from some point, and which is first of all engaging with other healthcare workers. And maybe we will get to the point where we will involve the traditional healers. But it's very important that we start involving the other healthcare workers. And adding to what Laura said earlier, the interventions that are in place are quite for the literates, and it's a bit difficult to be able to pass them on to the traditional healers, whom are mostly not a very literate people. So hopefully we will get to that point.
Great, thank you. Thank you very much, Paul, and thank you for our other speakers for your very thoughtful responses to those questions. I'm afraid we've come to time now. So just in finishing, I want to thank all of you who attended as well for your really helpful comments and questions and answers. I'm sorry we didn't get to address them all. I think just in closing to make a comment that maybe is very much in the mind of many people working in this area is the huge impact of the recent cuts that we've experienced in NTDs in this country. And I saw that someone had commented on the point whether this approach strengthens or does the opposite of strengthening our ability to mobilize resources. And actually, I think much of this work is very strongly aligned to the kind of system strengthening and universal health coverage type messages that I know is attractive to organizations like FCDO, who are really looking at integrated approaches. And I think we're definitely moving in that direction. So I think it's all to the good that we reinforce the great work that's been done historically in NTDs with these new kinds of approaches. So thank you very much, everyone, for your time. Thank you for the speakers for giving up your time to share your expertise with us. We will be following up with an email to those of you who've come along today. So we'd really value your thoughts on the session. I know the London Centre really wants to do more of this and to do it well. So I'll finish there and have a good rest of your days. Thank you.